Thank you so much. Very welcome to, and really excited to actually talk to you about irritable bowel disease. It's quite a big issue because it affects about 4.9 million people globally. In the US alone, there are about 1.6 million cases. IBD, irritable bowel disease, is a significant issue because it's so inflammatory. It affects the inflammation in the body, and it's quite different to IBD. IBD is quite different to IBS in that most of the symptoms are very similar, but they're quite distinct in their etiology and the presentation, and they have quite different underlying causes and management approaches. IBD, unfortunately, is not curable. However, it is treatable. The intestinal wall becomes so infiltrated with really chronic inflammation. We have a beautiful cytokine storm party going on in the gut in an IBD patient. There are two major conditions. IBS is a syndrome, so it's a multifactorial syndrome, and it incorporates a whole bunch of symptoms that are typically found in an IBD patient. But there are two conditions that fall under the banner of IBD, and that is ulcerative colitis, which is really inflammation of the mucosa. It doesn't really go deep down into the epithelial layers of the mucosa, of the epithelium. But Crohn's disease can actually affect the whole gut, from the mouth right down to the anus, and it's usually associated with, inflammation, fistulas, abscesses, etc. So IBS is, in actual fact, the underlying cause is obviously unknown. Symptoms, usually gas, bloating, diarrhea, constipation, etc. You'll find the same symptoms in IBD. However, in IBD, you'll have bloody stools, urgency to defecate, weight loss, nutritional depletion because of the blood loss, iron depletions, etc. IBD is an autoimmune condition, so it buggers up the immune system. The immune system attacks the digestive tract, and the prognosis is really it's quite a challenge to deal with IBD. Now, I'm not sure what's going on with my little pointer. The ulcerative colitis and Crohn's disease are quite different, but they have similarities in their inflammatory load. As we said, ulcerative colitis affects the mucosal lining, Crohn's affects the whole gut, right? The symptoms are quite the cardinal symptoms in ulcerative colitis, usually rectal bleeding, mucus in the bowel, bloody diarrhea, frequent stools as well. Whereas Crohn's, or CD, is the diarrhea associated with pain. The moment you eat, you will have pain, nutrient deficiencies, malabsorption, and then the malabsorption then leads to malabsorption-associated conditions such as osteoporosis or osteoarthritis, and that's then potentiated with abscesses and fistulas and so forth. So ulcerative colitis actually affects the inner lining of the mucosa. There's so many classifications. There's microscopic because it affects the you can actually identify it under the microscope. Lymphocytic, where there's infiltration of lymphocytes. Eosinophils, where it's accumulation of eosinophils in the lining of the colon. And there's some gene markers that are actually used to identify these conditions. HLA-B27, which is also used to identify other health conditions such as AS. Nitric oxide dismutase 2 is found significantly in your CD patients, interleukin-23 and FUT2 as well. So the symptoms of ulcerative colitis are, in actual fact, recurring diarrhea, abnormal pain, abdominal pain, irritation, all around irritation. And it's really it's ulceration of the lining of the mucosa within the gut. So when we have ulceration, if you have mouth ulcers, the system is acidic. The first key component here is to actually alkalinize the patient all the time. You will often find that any patient that has an IBD will have had, you ask them about their history, they would have had huge amounts of stresses and traumas through their life. Okay. And these people do not operate in a nice homeostatic level. They operate at an allostatic level. They're on this constant flight, freeze mechanism all the time. And that's their normal. And this then leads to upregulation of endotoxins such as hexa-LPS and all the other endotoxins that then drive down that immune tolerance in the mucosa of the gut. And that then leads to a whole chain reaction, which is part of an IBD picture. So ulcerative colitis is in actual fact can be classified on the basis of where it is in actual fact located. So ulcerative proctitis is found in about 50% of patients. It's treatable. There's no risk of colon cancer, but all the other forms of UCs are in actual fact have a higher risk of colon cancer. So ulcerative proctitis actually has it's milder, it develops into other types of UCs, you have the rectal bleeding, etc. But all the others, where it affects this proctosigmoiditis is in actual fact affecting the S-bend, and it goes up the descending colon. The left-sided colitis is in actual fact going all the way up into the splenic flexure. And then the worst case is of your pancolitis as well as extensive ulcerative colitis, where you're actually seeing that the whole colon is affected. These are patients that would probably have a colectomy because their colon is so ulcerated. About 20% of UC patients have rectal bleeding. They have, tenesmus, which is basically the feeling like you need to go and poo, and yet you've just emptied out your bowels and you still need to feel like you need to go and empty out your bowels. Toxic megacolon is a huge issue, particularly in the extensive ulcerative colitis and pancolitis. This is when your colon dilates so much and the inflammation is that severe that patients will develop fever, abdominal pain, distension, and they have the dehydration, they have malnutrition, and this then allows or opens up the platform for colonic rupture. So this is when only surgery can fix that. So Crohn's disease is in actual fact the other form of irritable bowel disease, and it affects any part of the colon. There's inflammation. It's generally transmural. Transmural means that it penetrates deep into the bowel wall, and you will typically see severe fistulas and abscesses, etc. Now, fistulas are really abnormal connections from the colon to the organ sitting next door to the colon. So that means that it's starting not only to affect the colon, like endometriosis, it affects the lining of the endometrium as well as the gut. The Crohn's disease does the same thing. It affects the colon and the organ sitting next door to it. And then abscesses are really when you have these pockets of pus that are caused by bacteria, and they form right inside the intestinal wall, causing them to bulge out. So abscesses can often lead to fistulas and form rectal strictures. And rectal strictures are really, it's, I guess you could say it's associated with restrictions of scar tissue that is caused by that chronic inflammation. And the area obviously then becomes blocked. The colon becomes blocked, severe constipation, and it can be life-threatening and often requires surgery. So obviously the genes again are affected there. So now we have your symptoms of Crohn's. As we mentioned, there's the same symptoms with all IBD patients, but here you will find, typically you'll find nausea and vomiting, and patients will start to feel really unwell. Actually, they'll have a low-grade fever. They'll have diarrhea. They find that they can't even eat, or eating is painful for them. So the types of colitis or Crohn's disease, can vary. And ileocolitis is possibly considered to be the most common. It's associated with diarrhea, cramping, and you'll find that it's kind of it starts in the ileum and in the small bowel. Again, you'll find fistulas, strictures, abscesses, etc. So all of these conditions fairly severe. Ileitis affects only the small intestine, so that's the ileum, and your gastroduodenal Crohn's disease affects about 5% of Crohn's disease patients. And then you have the granulomatous colitis that affects about 20% of Crohn's patients. Here you'll find bloody diarrhea, and it can actually be in patches as well, right? So you have the inflammation in various patches. And this is why surgeons would probably take bowel resections on different parts of the colon. So the drivers are in actual fact can be very, very varied. So you'll find that the microbiome now starts to become disrupted. The intestinal permeability changes. So you have what we call these microbiota. They actually ensure the integrity of the gut barrier by releasing these antibacterial molecules, which we call bacteriocins, and they release short-chain anti-inflammatory short-chain fatty acids and other metabolites that actually modulate the whole immune system. So after an immune response, you get increased epithelial activity, and that leads to dysbiosis. The commensal bacteria, they start to induce your Treg cells within the lymphoid tissue, to gut-associated lymphoid tissue, to moderate your Th1 activity, your cytokine inflammatory storms, right? You can also get, some of the latent viral infections, such as cytomegalovirus, has been shown to actually increase the rate of comorbid C. diff infections. So C. diff infections are, in actual fact, very important to rule out in an IBD, because that is quite typical in an IBD patient. Obviously, vitamin D, it's essential for Treg stimulation. Stress, diet, smoking, all of those factors are the major drivers for IBD. Of course, there are genetic predispositions as well. So the pathogenesis of IBD, there are many triggers. There's, infections, gastroenteritis, there's non-steroidal, repeated use of non-steroidal anti-inflammatory drugs have been shown in the literature to be associated with dysbiosis. Why? Because it's acidic, right? And that obviously affects the system. So regulating the pH is probably number one on the list when we're starting to actually manage some of these IBD patients. The triggers activate IBD, and they disrupt your balance of Th1, Th2 activity. They bugger up the microbiome, and you'll find that reduced bacterial diversity, such as your Firmicutes and Faecalibacterium prosnitsky. Faecalibacterium actually is needed. It's a commensal microbe that is needed to actually produce butyrates in your short-chain fatty acids. So we need a nice robust amount of Faecalibacterium in the diet or in the commensal microbes to ensure that we have enough of those short-chain fatty acids. So you have your bacteria chomping on the dietary fibers that your body takes on board in order to produce short-chain fatty acids, which are responsible for your immune integrity. So you must be aware that the toxic megacolon is part and parcel of bacterial toxins. People will develop your fever, etc. Hemorrhages, because of blood loss through the stool, one needs to be mindful and pay attention when you see somebody might have hemorrhagic shock or low blood pressure. Colon cancer is very, very typical in patients, higher risk of colon cancer in patients with IBD. Now, kidney stones, when we see oxalobacter is one marker that we would see in a microbiome assessment, a GI map, where kidney stones firstly have a higher prevalence in patients with IBD. Crohn's disease, particularly of the small intestine, they decrease the body's ability to absorb fat and protein, etc. And it leads to oxalate retention and stone formation. So because we have an increased risk of calcium oxalate stones in your IBD patients, we need to be mindful of it. So how do we assess IBD? So we can have a look at some conventional labs. So the conventional labs might be your full blood exams, your complete blood counts, your LFTs, inflammatory markers such as ESR and CRP. But we can also have a look at some of the scopes. The scopes are very important, your CT scan, endoscope, gastroscopy, colonoscopies, etc. So the scans can vary from your colonoscopy, your upper endoscopies, and then we can also identify your antibodies. So the antibodies that are identifiable outside of the scopes are some of the ones that are listed: Saccharomyces cerevisiae antibodies. These are more specific to Crohn's disease, and it's found in about 60 to 70% of cases. Antiflagellin and so forth and so on. There's quite a few there. Now, we are going to skim through some of these reports or slides because there's quite a lot of content and we have a limited amount of time. So one of the tests that I would use in conjunction with the standard blood tests, in conjunction with the scopes, etc., is the comprehensive testing. So this is a GI microbiome assessment. It identifies, it's a simple stool test. Patient can collect the sample from the privacy of their own home, send it off to the lab. And what we're identifying is physical attributes. Is there mucus in the stool? Is there blood in the stool? Some of the short chain fatty acids, some inflammation markers, the microbiology. So we have a look at your parasites, your opportunistic microbes, pathogenic bacteria, fungi, viruses, as well as the commensal microbes, and look at the diversity of those microbes. And then we also have a look at the sensitivities of those microbes to antimicrobials or antimycology treatment. So there's a number of ways that we can actually use this particular test. So here we have this patient who is a ulcerative colitis patient. She's a 62-year-old female. She has severe trauma events throughout her life, and she's in chronic constant stress. Bloody diarrhea, abdominal pain. This is a lady who found that she had lost about close to 15 kilos within a few months. And that the reason being is that she couldn't tolerate food, upset her. She could not tolerate any foods. She could have about 3 or 4 foods and that was it. Pain was significant. She would cry sitting on the potty. Headaches, fever, mouth ulcers, etc. Now, when we have a look at her test results, we can see the stool is unformed, mucus is detected, occult blood is positive. Now, when I see occult blood positive in a general patient, I'd ask about straining and hemorrhoids, etc., or anal fissures. But when you see an elevated occult blood with a high calprotectin is the primary surrogate marker for identification and differentiation between IBS and IBD. So if it's elevated, definitely inflammation, go and have an endoscope, it's likely to be IBD. So we can see this patient's butyrates are super low, and we need a robust amount of short-chain fatty acids in the system to actually ensure a powerful and robust immune integrity. Secretory IgA, nothing in the tank. So what secretory IgA does, it's this mucous membrane inside the colon wall. And it's in this mucous membrane that we, in actual fact, the immune system lives. This is where our sex hormones, our neurotransmitters, our immune system lives and is manufactured there so that we can fight against any of the offending agents, like a nutrient that you think might be a nutrient, but in actual fact is represented as an allergen. Secretory IgA recognizes it, chomps it out, and throws it out of the system. But in time, if you keep eating the same wrong foods, the secretory IgA will die down, the mucous membrane starts to deplete, and zonulin starts to rise. In other words, the tight junctions, the epithelial tight junction starts to break down. Leaky gut, right? So Dr. Alicio Fasano has actually shown in his literature that elevations in zonulin is not only associated with leaky gut, but also gluten intolerance. So get gluten out of the diet. Now, when we have a look at some of the normal bacteria, we can actually see that these are the commensal microbes. We've got high levels of Escherichia, we've got high levels of Clostridia, and these are two pathogens. These are commensal, right? These are the good bugs. These are commensals that can actually be shown to be pathogenic in an IBD patient. Oxalobacter, remember we talked about Oxalobacter? Nothing in the tank here. So that means that we need to remove the oxalates. Patients who have IBD, patients who have repeated use of antibiotics will tend to have lower Oxalobacter and a high propensity for kidney stones and obviously IBD. Akkermansia is possibly one of the major ones that we would actually look at in terms of, I guess we could say, mucin. It chomps on the mucin lining in the mucosa and to produce these short-chain fatty acids and to strengthen that intestinal barrier. Faecalibacterium prusnitsky. This is one of the ones that is involved in the production of butyrate. So we need that. And as you can see, there's very little in the tank there. So we need to be nice and robust in our diversity of that microbiome. So in the blood exams, we saw high levels of CRP, ESR. These are your inflammatory markers, low iron. Why? Because they're bleeding all the time, and low blood pressure. We see opportunistic microbes. Now, opportunistic means that they meant to be there. They live very happily in the bowel, but when they are out of range, they become pathogenic. And here we can see that not so worried about strep. Everybody's got some strep. But the Klebsiella pneumonia has been shown to be associated with IBD. Patient has candida as well. So here we actually see, bacterial pathogens such as your E. coli, enterohemorrhagic E. coli, your enteropathic E. coli, C. diff. C. diff is possibly, it's often caused by antibiotic-associated diarrhea, and the diagnosis and treatment of C. diff is crucial in any IBD patient, okay? So when we're looking at the management of IBD, we need to think about some of the treatment priorities. So through case history, we identify the potential key drivers. We need to increase the Treg cell production to actually encourage the regulation of these immune responses to actually reduce that Th1 upregulation, inflammatory processes. We need to think about nutritional and herbal support. because no matter, even if you're giving them all your aminosalicylates and all your immunomodulators, pharmaceutical modulators, you definitely, as an integrative practitioner, you definitely need to support the integrity of the gastrointestinal mucosa at all times, reduce the acidity in the system as well. So promote short-chain fatty acid production with commensals, replenish nutrient depletions, address the infections, etc. So in a nutshell, a very profound case history is important. We have to reduce the inflammation. We need to drive down those prostaglandin and leukotriene pathways. We need to support the immunity in the system, and we'll talk about some really great strategies to do that. Of course, diet plays such a major role, so we've got to remove all those offending agents, gluten-free, dairy-free, and so forth, okay? But the offending foods are predominantly your caffeine, your sugar, the gluten. Some people respond adversely to the nightshades, not all. You will find spicy foods tend to upset patients as well. So looking at a nutriently dense diet, providing adequate nutritional needs is very important, because some of the diets are in actual fact depleting of nutrients. So the diets for IBD can vary from your anti-inflammatory diet, your autoimmune protocol. The Crohn's disease exclusion diet is possibly, I guess you could say, the go-to for your IBD patients, because it excludes your wheat, your dairy, your animal products, your additives, your processed foods and the red meats, but it includes things like your fruit, vegetables, rice, potatoes, lean meats, eggs, protein. So it's the lean meats that it can tolerate, you know, a little bit of chicken, a little bit of fish, instead of the heavy to digest red meats, eggs, and so forth and so on. There are other diets, such as the low FODMAP diet, and this is basically, obviously, FODMAP is your fermentable oligo monosaccharides and your polyols. So what are you doing here? You've got to remove your sugars, your fructose, lactose, so dairy-free, wheat-free, sugar-free, polyols, and try and remove the fructans. These are your onions and garlic and leeks and so forth. And also remove the galacto-oligosaccharides. So patients that just cannot tolerate your lentils and your chickpeas and so forth. Okay, so these are some of the diets that you may want to consider. Your specific carbohydrate diet is, again, the problem with a lot of these diets, they can use that. Generally, I would pulse these diets. I'd use the Crohn's exclusion disease exclusion diet, and I'd pulse them with the low FODMAP diet, because you don't want, they get bored of the one diet, and secondly, you don't want nutrient depletion as a result of it. So the diets for IBD could be for your ulcerative colitis and exclusion diet. There's a number of trials that have been done, and it's been trialed with your fecal microbial transplants. So they found that the ulcerative colitis exclusion diet alone achieved higher remission and mucosal healing rates compared to your fecal microbial transplant with or without dietary modification. So the diet, is absolutely important for consideration when we're looking at treating some of these patients. One has to consider limiting the oxalates, and you can. It's not, you don't have to remove all the, the kale in the diet, for example, or the spinach in the diet. You don't have to. You can actually change the way you cook some of these foods. You can boil them or steam them and grill, etc. But a lot of the oxalate-rich foods are your beetroot, your legumes, cereal grains, etc. And so those may need to be limited. Now, with regard to prescription medicines, we have the aminosalicylates, and these are the go-to. That's where most doctors would put patients on your sulfasalazine, mesocelazine, etc. They all have side effect profiles. Corticosteroids are also used, and these ones are generally used as they're really effective, but side effect profiles, again, your prednisolone, cortisone acetates, etc. They have this, moon face, weight gain, osteoporosis. They leach the calcium out of the bone, so cause osteoporosis, mood swings, etc. So then we also have the newer, if your aminosalicylates and corticosteroids are not effective enough, that's when a gastroenterologist might incorporate some of the immunomodulators, things like thiopurines, azathioprines, etc. And so these agents are, in actual fact, problem with those, they suppress the immune system. So they increase the risk of lymphomas 2 to 3-fold. So, using these agents you need to be mindful of the side effect profiles. Methotrexate, cyclosporins, also used for various cancers, can also be used to drive down the inflammation. Some of the biologics are taking a lot of ground now, and these are biologics that are used in your asthma patients. They're used in your ankylosing spondylitis patients. They're also used so all of your autoimmune conditions, they're also used in IBD. So they actually suppress your inflammation for particularly in severe Crohn's disease and ulcerative colitis, particularly when they have the fistulas as well as the abscesses. Now, the new small molecules is the new kid on the block. They're also known as JAK inhibitors or Janus kinase inhibitors. They're blocking an enzyme involved in activating the body's immune system. So these agents are used especially when other treatments have been ineffective. Antidiarrheal agents as well are used, your standard loperamides and phenoxylates, and adjunctive therapies. So now we're going to be talking about some of the things that I think is very, very important from an integrative practitioner perspective is to identify what are the strategies that we can use as an adjunct to the current pharmaceutical therapies. So prebiotics are so important. After alkalinizing, prebiotics is definitely right up there with regard to management. So prebiotics is in actual fact your arabinogalactones, your slippery elm, the marshmallow. Arabinogalactones come from larch, lactoferrins, lactoalbumins, your GOS, which is your galacto-oligosaccharides. These oligosaccharides actually come a lot from the plant sources. Fructo-oligosaccharides. Problem with that is if you are fructose intolerant, you may not be able to use a FOS. Inulins are found in lots of food groups, great, but where it can trigger mast cell-induced constipation. So you may not, particularly in your methane-positive SIBO patients, you might not, you find that inulin upsets them, okay? A new kid on the block, or not so new, is your PHGG, partially hydrolyzed guar gum. So partially hydrolyzed guar gum, it contains these structural galactomannins, and they create this bloom of all sorts of beautiful bugs. So the good ones, these are ruminococcus and Faecalibacterium and Bacteroidetes, and they actually have the capacity to bind to roseburias and blautias, etc. So they actually allow for commensal microbes to bloom, and they bind to the pathogenic microbes. They support intestinal tissue health. You can use PHGG with people who are fructose intolerant or who have SIBO. So this is a great idea. Now, one very important one that I think is worth making mention is your 2-fucosilactose. The 2FLs are in actual, it's kind of a paradox. It's a new one right now on the marketplace, but in actual fact, it is the very oldest prebiotic known to mankind because it is derived from human milk oligosaccharides. So as long as a woman has been breastfeeding a baby, that's how long these human milk oligosaccharides are. So there was a time in the late 70s, 1970s, when people went out and looked for breast milk because they believed that that was actually helping the gut, which it did. Today, we have the availability of human milk oligosaccharides, which directly interact with the gut epithelial cells, resistant to enzymatic activity, and can benefit the host by normalizing the colonic function. Now, look at this. Your 2FLs can actually, they're bifidogenic, so they raise bifidobacteria. They're butyrogenic, they push up your short-chain fatty acids. They increase the short-chain fatty acids. They also will support the production or the maintenance of akkermansia as well. So this here is, there is a formulation that is a combination of zinc carnosine, which is also very important for gut mucosa, together with 2FL in these particular patients, which I think is a game changer for all our gut patients, whether it is IBD or, so typically what I would do is in a IBS-IBD patient, IBD, you have to be a lot more strategic in the treatment, but in an IBS patient, where we see most of our patients really, I would generally give them a broad spectrum anti-inflammatory prebiotic, things that contain curcumins and boswellias and all your slippery elms and marshmallows, etc. So that's what I would do together with the newer generation ones. So the new generation ones is 2FL, and another one is the serum bovine-derived support. So here we got serum SBIs, serum bovine-derived immunoglobulins. These ones bind to your microbial content. They maintain the GI balance. They manage your barrier function, and they directly bind to your commensal microbes. They actually allow for commensal microbes to bloom, and they bind to the baddies, the things like aflatoxins, gliadin, Klebsiella, salmonella. So these are great because they selectively bind to pathogenic microbes, and they also allow for the commensal microbes. So there's some really good studies on the SBIs. Okay, they actually have the capacity to drive down the LPS, the hexa LPS, and so prevent sepsis. They bind to, or they drive down the zymosan so that it can avoid aspergillosis. So these are the various ways. Now, probiotics. The science of probiotics has expanded so much. Now we have available, we can target using specific strains of probiotics, and there's a number of studies that have been shown to be very beneficial with your IBS-IBD patients. As a matter of fact, one study, or there's a number of studies, but one of them is 39 ulcerative UC patients. So these are ulcerative colitis patients who were taking Lactobacillus plantarum 299V for 24 weeks. And they saw a 56% reduction in the colitis scores, with 46% of them achieving remission. Now, that is quite significant. Probiotics have actually now expanded in their research. Have a look at the literature because we can be so targeted. There are certain probiotics that will support, neurotransmitter production and so forth as well. So now we have some of the other agents that are worth making mention of, and these are things like cooling soothing agents such as aloe vera, large arabinogalactones. These arabinogalactones actually reduce inflammatory mediators such as interleukin-8 and NF-kappa B. Wheatgrass, they've done randomized controlled studies on that, showing that endoscopy had improved, cellular structure had improved using wheatgrass. And these specialized pro-resolving mediators are in actual fact they trigger, these are your oils, the good oils, that trigger the switch from your pro-inflammatory M1 macrophages to an anti-inflammatory macrophage. So there's some really good things that are happening out there in terms of some of these agents. Some of the amino acids like glutamine and PEA, phenylethylamine, reduces the pain amplification. So 600 milligrams of PEA has been shown to reduce chronic pain scores from 71 to 21%. Now that's quite significant, right? So there are formulations with magnesium and PEA as well. Now, one of my favorite herbs is boswellia. Boswellia has been shown in the literature to actually be as effective as sulfasalazine in your colitis patients. There's a number of studies with boswellia and non-steroidal anti-inflammatories as well as for osteoarthritis. But as far as boswellia is concerned, it has been as effective as sulfasalazine in 102 Crohn's disease patients. And the mechanism, it inhibits your pro-inflammatory signaling. There's some really great other herbs such as devil's claw, curcumin. Curcumin has been well studied. 89 ulcerative colitis patients, they took 1 gram of curcumin twice a day with sulfasalazine or mesosalazine, and half was placebo with the prescription drugs. And they found that the curcumin significantly improved both the clinical activity index and the endoscopy. So other agents like astragalus, cordyceps, coriolis, these are all really very, very effective agents as well. So cannabis has also been shown to be very beneficial. 30 Crohn's disease patients, they were significantly improved after treatment. So here we go. There's some really great opportunities for an integrative practitioner to consider some of the nutrients. So, the management, therefore, we need to also think about what's new on the block. So we now have natural agents, which are called nanomolecules, and thymoquinone is actually an extract of nigella in a nanomolecule form, has been shown to be beneficial. Some of your vasoactive intestinal peptides, VIP, used for your mold patients, your natural polysaccharides. These are all new agents that are in trials at the moment. So now let's have a look at our patient. Remember, she was an ulcerative colitis patient. She had her IV antibiotics. She was extremely sick. She had IV antibiotics. She was on a specific diet where she ate only white bread and white rice, etc., nothing with peels, etc. And we then popped her onto, once she's gone through this acute phase, she was sent home. We then popped her onto the ulcerative colitis exclusion diet, and we pulsed that along with the low FODMAP diet. Alkalizing salts in her drinking water all the time, because remember, these patients are mineral depleted, right? We gave her herbal antimicrobials. Now, she had a number of, remember, she was on IV antibiotics for her E. coli as well as the C. diff infections. So now we have to actually ensure further eradication of any other microbes. So we gave a course of the herbal antimicrobials with berberine, pordaco for your fungal infections, cryptolepis, these are your berberine, bur marigolds, astragalus, etc. We gave her 2 prebiotics. One was with a combination of curcumin, boswellia, arabinogalactone, slippery elm, marshmallow, all of these soothing, cooling, demulcent agents, together with the 2-FL and the zincarnosine. Then we pulsed her probiotics. We gave a multi-strain probiotic. We gave another probiotic, Rhamnosus GG, and then we gave her one that had Lactobacillus fermentin. And the reason I used fermentin ME3 is because this has been shown in the literature to actually upregulate glutathione production. We know that a liver's not working properly. Her transsulfuration, CBS pathways need support. Her cystathione pathway needs support. We know that. We know also that she's terribly exhausted. Every IBD patient is super tired. So we therefore need to ensure that we are supporting that. So doing double whammy in a way, giving her 2 days of each of these probiotics and pulsing them along. Of course, diet, limiting certain foods. We've discussed the food groups. We've got to focus on the fruits and the vegetables, no peels, etc., whole grains, and reintroduce it, knowing when to reintroduce some of the foods as well. So it's very interesting when we actually see her results before, which you've seen earlier on in this presentation. And this was done about 8 weeks after her original test assessment. And we found that she stopped bleeding. That was a good thing. Her calprotectin was still high. You're right. It's 86. It's still high. It's now 83. It's quite high. So we still need to drive that down a bit, right? So we still need the anti-inflammatory agents. The secretory IgA was low. The zonulin was high. The secretory IgA is still low, but within normal range. Zonulin is still high. It's actually gone worse, but we need to actually therefore make sure that we are restoring that dysbiosis, right? Then we had a look at her normal bacteria, and we saw that her normal bacteria were really up and down like a yo-yo, right? We saw that her commensal microbes, Clostridium and Escherichia, were high. And we know how important it is to ensure that the Oxalobacter, Akkermansia, Faecalibacterium are upregulated, and we saw that they started to normalize. Faecalibacterium was still on the low side, but they started to normalize. This shifts the patient's physiology to such a point where they find that they can actually cope with their lives and manage what's going on. As far as the opportunistic microbes were concerned, we saw that the ecology started to improve. Klebsiella was still there. Mind you, Klebsiella pneumonia went from 86 right down to 0.13. So this is great when you're using, we know that the IV antibiotics worked for this patient, but the subsequent herbal antimicrobials obviously made a difference as well. Now, as far as the pathogens are concerned, we also saw that she had C. diff toxin A and B as well as E. coli, and we now see that that has been eradicated. So there's some really great strategies for our patients who have IBD. It is important that you do look into the pharmaceutical process, the endoscopies, and support the system adjunctively. And now we will open up for some question time.
Hi, everyone. We hope you enjoyed this class. If you're a practitioner, make sure you go sign up at rupahealth.com. And if you like this video, don't forget to like and subscribe.